Good evening and welcome to Doctors on Call. I'm Mary Morehouse, psychotherapist at Insight Counseling Duluth, where I specialize in working with anxiety for teens, young adults, and parents. I'm your host for our program tonight on the DSM-5 Comes Alive. The success of this program is very dependent on you, the viewer, so please call in your questions or send them in our email at ask@pbsnorth.org. Our panelists this evening include Dr. Nathan Chan, a psychiatrist at Aspirus St. Luke's Behavioral Health Clinic in Duluth, Mike Claybaugh, LGSW at Insight Counseling Duluth, and Dr. David Plood, psychologist at Arrowhead Psychological Clinic in Duluth. Volunteers are standing by to answer your calls. And now, on to tonight's program, the DSM-5 Comes Alive. All right, thank you, gentlemen, so much for coming on this show. So the DSM-5 Comes Alive. So just so everyone knows what the DSM-5 is, it's kind of the Bible for psychology. It's the Diagnostic and Statistical Manual, the 5th edition. And so this is the manual of all psychological disorders that we have to, that we treat, and so that we have to, that are available to us. And so that is what I mean by the DSM-5 Comes Alive. And so it is kind of this broad kind of a question, and there's so much out there on social media of oh, I have anxiety, oh, I'm so depressed, I'm so OCD, and so all these psychological terms are being thrown around, which is great that we're talking about mental health more, but I thought this would be a great opportunity to use a group of experts to try and answer some of those questions. So first of all, I'm going to have you go along and just answer, just tell me a little bit about what your specialty is, Dr. Chan.
Yeah, so I'm a general adult psychiatrist at Aspirus St. Luke's, mostly 18 and up, every now and then maybe a late teen. And we kind of treat any disorder that will come into the clinic needing help, whether it's mood disorders, anxiety disorders, ADHD, substance use disorders. We don't necessarily pick and choose and try to confine ourselves to one disorder. We treat whatever comes in the building.
Okay, great, wonderful, thank you. Mike, tell us a little bit about where you work and your practice, what you specialize in.
So I'm a psychotherapist at Insight Counseling and work with anxiety, depression, PTSD couples, just kind of the general mental health conditions that people face. And I would want to say one thing at the beginning, at the outset here, is
absolutely.
I think that pretty soon we're going to get rid of the idea of these are disorders. Already we say, instead of PTSD, post-traumatic stress disorder, sometimes we'll just say post-traumatic stress, because people, there's a stigma that goes with saying I have a disorder, and I just really want to throw that out there, that if you have anxiety, and you shouldn't really think of it as a disorder.
Yeah, and thank you very much. I like that, and or even I am having these thoughts that happen to be anxious right now. So even depersonalize them even more.
Yep.
All right, Dr. Plood, tell us a little bit about your practice and where you work.
Yeah, I'm up at Arrowhead Psychological Clinic. I've been doing counseling and therapy and some assessment there for the past 30 years or so. I do a lot of couples work, a lot of family work. Started off in the career working with younger ones because I was such a young guy, and as my hair's gotten grayer, older populations are coming in and families and whatnot. Do some sports psych and wide variety of things.
Yeah. Great, wonderful. We have a great panel here. So let's dive in. So depression and mood disorders, Dr. Chan, if I could just start with you. So statistics range, but about 7 to 10% of U.S. adults annually could be diagnosed with some sort of depression or mood disorder, which is major depressive disorder, bipolar disorder, and seasonal affective disorder, which, if you could speak, right, is we live in a
up here,
up here is
not so uncommon.
No, not so uncommon. So, can you tell me a little bit about how some of the? I know this is obviously very general, but some of the ways that you would treat depression. Really, what do you see in your clinic with major depressive disorders?
Sure, I think it's certainly one of the most common things that kind of presents, especially within a specialty clinic. Other things like anxiety disorders often come up and mood disorders often come up in the primary care setting. But I think when things get severe enough and symptoms are difficult enough to manage, which depression often is, we see it in a psychiatry clinic. And our tools and our medications in particular, I think, are imperfect. I think we're developing new treatments, and we have an expanding toolbox of options. But a lot of patients have been through a gamut of treatments that have worked partially, maybe have had a lot of side effects, maybe they've had difficulty achieving the remission. So our job, I feel like, as a specialist, is to navigate what has worked, what has not worked, and try to tailor a regimen to a patient as an individual rather than as a diagnosis, and kind of come up with something that may be a new avenue of treatment, or maybe something that it's just a different approach of what they've tried before. And we're in an era now of I think psychiatry, psychopharmacology, therapy as well as a whole, where it's kind of exciting to be part of, because we are developing new treatments that are working, and they're having either less side effects or becoming more available. I would consider something like transcranial magnetic stimulation in that category. I would consider something like S-ketamine treatments, whether it's a nasal spray or ketamine infusions, as treatments that are now more and more common.
And specifically for depression.
Specifically for depression, yep.
Okay.
There may be some utility in these treatments in other illnesses. Right now, just the way that payments and insurance are handled, those are the depression seems to be the most common thing that is covered and available, and evidence-wise is responding best to the methodologies we have in these treatments right now. Okay.
And actually, I'm going to follow up with you with a question, and I may have to have you pronounce that word.
Okay, yeah, I was going to say we got it. Is this from a caller? We have
yes, a caller.
Is the treatment of propranolol used often?
There you go. Thank you very much.
I think that's a fantastic medication. I would say that the most common use for that is something like social anxiety, or like almost like it's like stage fright. If someone has to give a speech, has to be on stage, has to play in a recital, has to be at a business meeting, and they're noticing a lot of physiologic symptoms. They're heart racing. They can't get on stage. They can't get the words out. That's a medication that's been proven to kind of reduce that kind of almost fight or flight response. There are some situations where it works to lower anxiety in other situations as well. The main benefit of that medication, I think, is that it does tend to work for that option, and it's also very safe. I would consider there's a few things we need to be worried about with the cardiac system, but outside of that, it's one of the options that is very safe to use overall.
Okay, great. Thank you very much. Mike, if you could talk about anxiety disorders. About 19% of the U.S. adults annually would be diagnosed with some sort of, again, I know we're going to use the word disorder because that's the current talk, but I like where we're headed for taking off the disorder. So generalized anxiety, panic, social anxiety, and specific phobias. So again, just kind of a general, what you see in the clinic, and then like how it presents in some of the tools kind of that you would use.
Yeah, so I think depression and anxiety are kind of the common colds of the mental health world.
Yeah.
And I mean, in its most basic terms, depression is often focused back towards the past, and anxiety is often said to be focused towards the future. A lot of people with anxiety, it's worry. It's going through all the what ifs might happen. It's going with worst case scenarios and so forth there. And so really, anxiety, again, activates that fight or flight response system, and it gets them very shaky, heart rate goes up, and it really gets hard to think your way through your anxiety. The more you think about it, the more anxious you can become and so forth there. Yeah. So yeah, I work with a lot of clients with anxiety and doing that.
And the self-fulfilling prophecy, the more I say going down the rabbit holes, and then and then's the emotion mind that you just, and then this could happen, and this could happen, and then this, and then and then off to the races we go. So just trying to be able to stop that.
Yep. Yeah. And a lot of it, I mean, they call it the default mode network, which is, when we're not really doing something like task focus, like making dinner or something, then the default mode network takes over and really starts to say, how are we doing today? How are you doing today? And then if you have a little bit of anxiety, it's like, well, how am I doing today? Well, I start to kick this anxiety loop going, and it gets hard to get out of.
Yeah. All right. Dave, if you could talk a little bit about ADHD and its prevalence. And so ADHD, again, autism spectrum, which I know is but it's just also another neurodevelopmental kind of disorder. So tell us a little bit about ADHD, how it presents in the clinic, how you do testing for it, and things like that.
Yeah, ADHD is a little bit of a different animal than the depression and anxiety. With depression and anxiety, I'd be thinking, all right, counseling, meds, exercise, all wonderful interventions that can be really helpful. ADHD is a little bit different. It really involves slowing of the prefrontal cortex and kind of slowed executive functions, planning, impulse control, judgment, those types of things are the biggies there. And so one of the best courses of treatment that I've seen over the past 30 years is the use of stimulant medications for correcting that. But the counseling element is really helpful too in terms of helping with parents, helping with behavioral modification programs, reward systems, that type of stuff, structure, organization, and whatnot. A couple other big things. ADD is probably, I did some research up at UMD. We did free neuropsych evals for all the student population up there, like an ADHD screening. At the end of the study, 70% of the students that came in for the study actually had some type of anxiety disorder. So they're very easily confused. And the only real way to flush it out, from what I've seen, is a little bit more of a comprehensive neuropsych eval where you're actually assessing attention. The rating scales aren't quite as accurate, because if you feel you have ADHD or your parents do, then they're going to say, is Johnny hyper? Yes, right? Can he, right? And so they're so face valid that if you believe in it, it can be misdiagnosed. So they're both very real, but oftentimes really confused. And fundamentally almost opposing conditions in terms of treatments. With anxiety, you're going to try to help people slow down a little bit. With ADHD, you're actually trying to stimulate the prefrontal cortex.
Yeah. At what point would a parent or an adult to say, you know what, I think my symptoms of attention deficit are maybe rise to the level I might have to get tested? What is that kind of litmus test for you? Like, what is that? Yeah, maybe you should get tested.
It's an awesome question, really, for everything we've chatted about here already. I remember when I was in abnormal psych, and this is where we study all the diagnoses, and the professor says, now be careful, because you're going to diagnose yourself with about 300 of these things, okay? But the real distinguishing factor that I like to look for, and it oftentimes spells it out in our manual as well, is it interfering with relationships? Is it interfering with school? Is it interfering with work? Okay, is it causing clinically significant difficulties in those areas? And I think it fits with just about everything here.
In more than one area in life, right? And so usually, so if I see it, so with parents, I know sometimes my child may have it at home, but they're little angels at school, or they, that vice versa. Is it kind of that like for kind of that?
Yeah, because that could be kind of a parenting type parent-child dynamic, or if it's just at school, it could be a teacher and child dynamic. Yeah, so I think if it's generalized through these different areas, that's like, okay, let's get this checked out.
Then it's a good idea to get checked out, and then to call and ask for an assessment for ADHD or something like that?
I mean, they could get in with a variety of counselors where they could walk through symptomology and try to determine, is this a good one to send off for psych testing? Or is it clearly enough an anxiety-based attention-related issue or depression?
Have you guys noticed in your practices that there's been an increase in patients you've seen on social media or TikTok or something that, based on TikTok, this 5-second clip, I probably have ADHD because I bumped into a door once?
Yeah, for sure. And I mean, there's even trends diagnostically too. I think 90s was the decade of ADHD, and now we're kind of into the autism trend, it seems like, which has become a lot more popular.
A lot more popular.
Or more recognized or more understood.
Yeah, and if you see these signs in your toddler, they're, the early signs of autism was spinning. Well, every toddler spins, and so it's you can't look at these 5 seconds, which again kind of goes back to what I was talking at the beginning. And so again, there's so much talk about mental health, and social media is not a bad thing, but getting your mental health information exclusively from social media that isn't an established psychiatrists, psychotherapists, or psychologists.
There's a lot of opinions out there, right?
There are a lot of opinions,
Yeah.
right? And so that's what. So the DSM-5, right? These are the facts, right? And so that's what I was kind of hoping to get to tonight. Yeah,
And I would just say too, since we brought up autism, I mean,
Yeah.
it is such a spectrum condition, and I think people often think of autism and Rain Man, you know, and that it has to be that, whereas people can have autism and be very highly functioning, and you can't even tell that they have autism. And so I think it's really important to, I mean, that's part of all of the mental health conditions that we're working with, is they're so varied. It's very hard to put something in a box and say, okay, here it is, here's all the boundaries around it, and then it's going to go from this person to that person to that person. It's going to be unique everywhere.
Yeah, which is a challenge, right? And so what I was speaking to earlier about, I have anxiety. I have these thoughts that happen to be anxious sometimes. I have these thoughts that are some depressive. I have impulse control sometimes. These things come and go, but it's not to identify so closely sometimes with some of these mental health things that we're talking about tonight. And so I don't think, no matter what your diagnosis is, you are not your disorder. No matter, and you're nowhere in any DSM-5, you are not that. You are the person, what you spoke to. Like this, how can I treat this person? Yes, this may, I see a lot of anxiety, and my 8th person that day that I am talking to with anxiety, it is as unique as they are, right? It's as unique as their fingerprints. And so I think that some of these generalized things that are out there aren't as unique.
And I think there's actually a way to look at the DSM numbers and make a case for that, because just as an example, if we look at something like major depressive disorder, the criteria, you need to meet 5 out of 7 criteria, have a couple, 2+ weeks, but mathematically, there's about, I think it's 227 different permutations of symptoms that can result in a diagnosis of major depression. And as a clinician, that lines up, because no patient with depression is exactly the same as another patient. Your approach to treatment is going to be different too. And kind of like what Dave was saying about symptoms overlapping in a lot of these things. Again, if we look at the numbers, there's about 250, I think 58 diagnoses in the DSM. Do you know how many symptoms there are? There's 102. So that's to say that there's a lot of overlap. And if you pick a handful of symptoms that many people live with on a daily basis, statistically you're likely to qualify for some of those things, because we only have a handful of ways of describing these things, even if they're just different disease processes.
Yeah, I think
which is a really good point with the DSM, is what we're looking at are symptoms. And so we're not finding the cause of the symptoms. So you can't do a blood test to find depression or an fMRI. So we're just looking at symptomatology and then making best guesses as to what's behind that, and then trying to figure out the cause if we can.
Yeah, which actually leads me to our next question from a viewer. Talk a little bit, and this I'm going to go for Dr. Chan. Talk a little bit about why some antidepressants work better than others depending on the person's genetics. And I have, again, as a therapist, I have had clients come in with their blood results.
Yeah, genetic testing.
Genetic testing, and trying to figure out which is heavier, their anxiety or depression. So those are always like, which should I treat? Is it the anxiety or the depression? Which one do you think is? So those are always. But can you talk a little bit about this new, at least in the last couple of years, these blood tests for genetic markers for medication?
Yeah, absolutely. I think it's a very common question. We have a lot of patients who inquire about that, even at the outset, even if they've never tried meds. I think it's difficult to assess, because I think our understanding both of our medications, but also even of the disease process of our brain is so advanced that it's tough to understand and pick amongst our dozens of first-line agents what's the right medication for a given patient. Our genetic testing, I think, is okay at telling us how our medications are metabolized through our body, but because we don't even have a complete understanding of the mechanism by which patients improve on these medications, it's hard to pick, even if we know the metabolism, how a patient may respond to a medication, whether or not it's in a green category or red category in genetic testing. The best, I think, genetic testing that has worked in my practice is what has worked in the family. There seems to be something related to the biology of our DNA, such that if escitalopram has worked in a parent or a child, then that's a likely responder for a patient. But ultimately, it's just that we don't have a great understanding of exactly how these meds are working at whatever the micro level may be, that we can say, yep, this is the perfect med for you. We're going to give you a blood test. We're going to give you this, and you're going to be great.
Yeah, not there yet.
One day maybe.
One day maybe, but interesting. So, Mike, I'm going to ask you this one about what are some of the benefits of pursuing a diagnosis of ADHD or autism as an adult, and are you ever too old for help?
The second question is no.
Yeah, exactly.
No.
Never too old.
That's a great question, because I have worked with many people who find getting a diagnosis is completely liberating and freeing.
Yeah.
If you get diagnosed with autism as an adult, it can explain so much, and you realize, wow, it wasn't me. I'm autistic.
Yeah.
And that's why I have trouble in social situations, or that's why I need my space to be consistent and not have any change. So yeah.
Yeah. So never too old. Never too old to get.
And never too old. No.
Never too old to get help.
No.
Yeah. Dave, how do you treat ADHD differently in children and adults? What would be like some of the mechanisms that you would do?
Yeah, again, going back to what we talked about earlier, I think the stimulant medicine intervention is probably by far and the most effective intervention for ADHD. The counseling component to it, I think, is very similar. Also for both populations, it's going to be structure, organization. If there's a hyperactivity component, there's going to be outlets for energy. Oftentimes there's needed outlets for a creativity kind of element too, in terms of just how folks are wired. But it's not too different. It's just that the parents are probably going to have to be managing the implementation of different structures, different reminder systems, and whatnot for their child, and helping them until they're capable of doing it more on their own, whereas the parent can fire up the smartphone and get reminders going all over the place and get notes all over the place. And so I think it's really just structuring the behavioral modification organization structure in the counseling realm.
Yeah, and then, for a parent who has a child with ADHD who doesn't really understand it, to get education and to kind of help, because I think especially if as a smaller child gets diagnosed, to try and understand that.
Yeah, and that can give parents fits, because there might be one parent that didn't grow up with ADHD, but the other did.
Yeah.
And so the non-ADHD parent is looking at their child going, oh my gosh, what is going on?
Saying, that's me.
Right. And don't worry about it. We'll just bring his glasses to school for him, because he's going to forget them once a week.
Yeah.
And just kind of be a little bit more able to roll with it. And
Yeah.
Yeah.
One's more laid back, and one's
Yeah.
like, I recognize this as a
Yeah.
child.
Yeah.
I could never. Yeah. I've never been diagnosed, but I forgot a lot of books at home. A lot of books at home. And so I think that's the kind of the nuance. And so I think that is kind of like, you can have some of these elements, and I say this in clinic, I'm like, I have elements of ADHD. I wouldn't be diagnosed, but you can have elements of that, elements of personality disorders, right? And that's something we didn't touch on tonight, but maybe, next season we can do one on personality disorders, on how, you can have elements of, they're so narcissistic, or they're so OCD and things like that. And so I think to kind of have that nuance of, we can have some of these characteristics, and we have, but we don't have to self-identify as them. And so I think that's kind of an important,
I agree.
Yeah, important. All right. I want to thank our panelists, Dr. Nathan Chan, Mike Claybaugh, and Dr. David Plew. Doctors on Call is on hiatus until the fall. If you missed a program, go to pbsnorth.org for a complete list of shows from this season. Thank you for watching and for joining us all season long for Doctors on Call. Good night.